Hi, my name is Marta Carrera and I'm the Scientific and Medical Director of inCode. Today, I would like to draw your attention to the polygenic risk scores that are in use in familial hypercholesterolemia. Genetic variation can predispose to disease both through monogenic and polygenic risk. Monogenic risk variants for a specific disease are normally present in a reduced number of genes, are rare, but have a large effect on the phenotype. On the contrary, genetic variants involved in polygenic risk are present in multiple genes, are common, and have a small individual effect on the phenotype. Therefore, it's the accumulation of multiple genetic variants in multiple genes that has a large effect on the phenotype. Monogenic and polygenic risk contributions to a particular disease can be present at the same time in an individual, and extremely high polygenic contributions can confer a disease risk equivalent to a monogenic contribution. These two situations have been described for FH. The guidelines for clinical genetic testing for FH from the JACC Scientific Expert Panel and a recent editorial in the same journal have both highlighted that the analysis of a small number of genes related to FH, like the three classical ones, LDL receptor, ApoB, and PCSK9, is not enough, and a broader list of genes is advisable. The presence of polygenic hypercholesterolemia should be evaluated, and a broader analysis of the coronary genetic risk should be performed as well. This is because the genetic heterogeneity in cardiovascular risk in FH remains inadequately understood, but likely involves genetic variation that affects both LDL cholesterol levels and broader cardiovascular risk. In this sense, lipid inCode is a comprehensive genetic diagnostic tool that covers the diagnosis of familial hypercholesterolemia and related phenotypes by analyzing a panel of 7 candidate genes for monogenic variants, the diagnosis of polygenic hypercholesterolemia by means of the LDL cholesterol score, described and validated by Talmud and Futema, and the evaluation of the coronary genetic risk by means of the inCode score validated in over 80,000 patients. Additionally, lipid inCode also gives information for patient management, such as statin pharmacogenetics and the genetic predisposition to high LPA levels. Polygenic hypercholesterolemia is assessed by the LDL cholesterol score, which evaluates 12 single nucleotide variants involved in rising LDL cholesterol levels. A LDL cholesterol value in deciles 9 and 10 is classified as high and indicates a high probability of polygenic hypercholesterolemia. Numerous studies reveal that from 20 to 30% of patients with suspicion of FH with at least a possible clinical diagnosis have a high LDL cholesterol score and therefore polygenic hypercholesterolemia. Thus, polygenic hypercholesterolemia may explain high LDL cholesterol levels of FH negative patients. The diagnosis of polygenic hypercholesterolemia is also important for other family members, as 30% of relatives of patients with only PH also have high LDL cholesterol levels. As revealed by recent publications, genetically based hypercholesterolemia, either monogenic or polygenic, is associated with an increased cardiovascular risk in comparison with non-genetic hypercholesterolemia, and the type and number of the genetic contributions to hypercholesterolemia determine the patient's cardiovascular risk. In this respect, the monogenic contribution has a higher cardiovascular risk, and the polygenic one is associated with an intermediate cardiovascular risk in comparison with monogenic and non-genetic hypercholesterolemia. And those patients with both monogenic and polygenic contributions to hypercholesterolemia are the subgroup with the highest cardiovascular risk. Therefore, the analysis of the two genetic contributions to hypercholesterolemia allows a better stratification of the patient's cardiovascular risk, which has implications for the clinical and therapeutic patient's management. There is a coronary genetic risk that in the general population increases the risk of cardiovascular disease both in primary and secondary prevention, and certain subjects in the upper band of the high-risk group have a coronary risk equivalent to that of heterozygous FH. Also in the context of FH, recent publications reveal that an additional coronary genetic risk increases the patient's overall cardiovascular risk. Thus, the analysis of the coronary genetic risk in FH enables a better stratification of the patient's cardiovascular risk, which also has implications for the clinical and therapeutic management. We assess the coronary genetic risk by means of inCode score, which evaluates 12 single nucleotide variants independent from classical risk factors and which has been validated in more than 80,000 individuals from different populations. In our experience with inCode score, 2% of the general population have a coronary genetic risk equivalent to that of heterozygous FH, which is present in 0.4% of the population. In our experience with lipid inCode in the analysis of more than 5,000 index cases, 27% have a polygenic hypercholesterolemia, 22% if FH positive and 32% if negative. 8% have a double genetic contribution to hypercholesterolemia, both monogenic and polygenic contributions in the same patient. 45% have a high coronary genetic risk, and 5% have a coronary genetic risk equivalent to that of heterozygous FH. 16% have a double genetic contribution to coronary risk, both monogenic and polygenic contributions in the same patient. And finally, 3% have a triple genetic contribution, monogenic and polygenic contributions to hypercholesterolemia and coronary risk in the same patient. A very recent paper reveals that polygenic contributions to cardiovascular risk, such as LDL cholesterol score and inCode score, modulate the effect of the monogenic contribution to FH. Therefore, it is important to evaluate both polygenic contributions in all FH index cases. To conclude, overall and comprehensive genetic assessment of FH improves the diagnosis, cardiovascular risk stratification, and patients' clinical and therapeutic management by reporting lifetime risk regardless of the presence or severity of the clinical and subclinical phenotype at the time of diagnosis. The inclusion of polygenic risk scores, both for polygenic hypercholesterolemia and for the coronary genetic risk, allows for the identification of additional cardiovascular risk also in patients with monogenic variants. This enables a more personalized approach to clinical and therapeutic management by detecting cardiovascular risk gradients. Thus, patients with more than one genetic contribution are an extremely high-risk population who could benefit from an intensive and early lifestyle intervention, an early assessment of subclinical atherosclerosis, and an early start of more aggressive treatment. Thank you very much for your attention. We will be more than happy to answer all your requests. Would you contact us by email or through our web page?